a couple of hours or so. But really pleased to pass over to Sean Russell from the Global Leadership Exchange, who's going to talk us through some of the international mental health benchmarking. Welcome, Sean.
Thank you so much, and really great that we could be here this afternoon and part of this network. So I'm Sean Russell, I'm the COO and European lead for Global Leadership Exchange. And what we try to do is to try and think about how we work with countries across the world to develop and support leaders, really around leadership, but more so about actually how do we ensure that we get the best practice and knowledge and experience to those individuals through our network. Next slide, please. So I'm going to do a bit of a background as to what GLE is, and then I'll go into some details around our benchmarking network. So Global Leadership Exchange, as I said earlier, connects leaders in mental health, disability, addiction and substance use. And we create the space for sharing of ideas, knowledge and best practice. And our benchmarking network is one of our really good practice networks that we've been operating for a number of years now. And what we do through the networks is help to spread innovation, improve services and change the lives of the individuals that we're working with in our communities. Our members come from all over the world and they're really engaged in that leading of change, which is really, really important to us because I think for us, it's a really growing area of interest. And what we want to know is actually, we don't want to keep reinventing the wheel, but there's lots of things going all over the world that go on. How do we make sure that we share that really good experience with other people? So in our network, some people have got lots and lots of years of experience, so really seasoned leaders. And actually, some of them are just starting out on their career. And what we try to think about is how do we create that cross-sectional learning between established and new leaders through to enable us really to grow in our ambition and share our knowledge. We work with organisations, so the NHS is one of the organisations we work with in England, but also across the world we work with organisational leads, policy leads, government service experts and by experience as well as experts by occupation. And we work with academic and faith leaders and lots of VCSOs and charity networks across the world. And actually our network isn't necessarily just including the sort of health-based sector. We come from people from housing, from education, from the justice system, and really try to think about how we think about the wider determinants of health to really focus on that sort of agenda around mental health and addiction and disability. Next slide, please. Whenever you join GLE, there'll be an opportunity later on just to scan a QR code to join. It is free for anyone in England to join. We ask them to sign up to our principles, which is basically a set of principles that we operate to. What we want to try and do is ensure that our environments when we're networking are really fair, authentic, they're sort of collaborative, but also underpinned with a set of values which really align to the NHS value set, really, to make sure that we're really thoughtful about creating that psychological safe space. And what we want to do is help enable people to share in that space to do that effectively. Next slide, please. So if you're a member of GLE, we have an online portal, which is coming soon, but we have a knowledge exchange collaborations, which we've got about 17 of them. I'll describe a few in a moment. We have a leadership exchange which takes place globally every 2 years. We have a monthly newsletter that comes out, and then we work with organisations to share reports and publications and think about how we expose that knowledge and innovation across our network through webinars, podcasts, and a whole host of elements. And our beauty of this is actually in England, our lead for England is Peter Molyneux, an exceptional leader, actually done lots of work in this space. Around leading health trust, but also in the housing frame. So for us, it's really exciting that we get different people coming along with different levels and skills. Next piece, please. So we're a small team actually, but we operate really to develop a network which talks about our in-country network. So how do we operate in England? How do we operate in Northern Ireland or in Wales or Scotland? But also the same as we do in Netherlands and Sweden, US, Canada, Australia and New Zealand, and now the Pacific region as well. And we're growing further into Europe with some work in Ukraine, some work that we're doing in the Czech Republic, some work that we're doing in Italy, Slovakia. I've just been out in France actually to try and build our connection points there. We have a really strong lived experience council as well. We're really focusing on actually the role of peer support and peer leadership as well. And actually on the right hand side, you'll see our networks and themes. So actually all of the things that we talk about here today, benchmarking is one of them. But actually we have a really strong series of networks which uses data really and innovation to really drive their ambition and delivery. Next one, please. So we are led by Steve Appleton, our President and Chief Executive Officer. Most of us are contractors who work a couple of days a week, and we work flexibly really to think about how we operate in the countries that we've got connected down below. We've got about 5,000 members who are subscribed to our network all over the world, which is really lovely because we bump into people now when we're at conferences from Japan, from Korea, but also from India, and we're starting to engage colleagues in South Africa and South America. So what we're starting to think about is actually how do we collaborate more broadly on a system. Next one, please. So this is a bit of a snapshot very quickly of what we do. You can see this on our website if you want to have a look. But actually building on this really, our benchmarking is one of our really, really strong networks. And what we try to do then is think about how we activate and amplify the work that we're doing. And here's just a couple of examples of what we do and how we do it. Next one, please. So the International Benchmarking Network has been running now since 2016. We've got a number of countries on the right-hand side. You'll see all the flags that have been operating with us and thinking about actually how do we share knowledge and experience around what benchmarking looks like across all of the different countries that we operate to and within. And this is really, really important for us is because I come from a world where actually we look at data and quite often we compare data with apples against apples. But when you're working across different contexts globally, it's really complicated. So you may end up working on apples versus pears versus kiwis versus pineapples, as an example. And it's really, really complicated. So the benchmarking network is trying to get to a position where we can pick out some indicators that bring some reality and leveling really around how people are doing. I'm going to show some slides in a second which really help us to demonstrate actually the value of benchmarking and how you can start to shine a light in some particular areas to see who's doing some really good work across the world and therefore where areas there may be for improvement. And I think this has proved really, really exciting over the last 5 years and coming up towards 9 years that the group has been operating now, but started to think about actually how do we demonstrate what goes on internationally. Most of us in our day-to-day job are pretty focused on what's happening around us. We don't really have the time and space to look up and to think about what's going on an international context. So having the benchmarking network has proved really, really vital to really share great practice across the globe. Next one, please. So in 2022, we worked with the International Benchmarking Network and provided a report. It was just as we were transitioning from the IIMHL, which is the International Initiative for Mental Health Leadership, to Global Leadership Exchange. And we were working with the benchmarking network that you're on the call today with today and other partners. And what we wanted to do across the globe was try and compare mental health service provision to inform policy, practice and professional dialogue. And that's the bit for me that's really, really important about how do you help leaders be the best versions of them by sharing information, intelligence with them. So this is really significant for us actually, because it was the first international comparison report since the COVID-19 pandemic. And we all remember those days when it was really, really complicated. And some of the things that we were looking particularly to the international framework was actually what was going on in Australia from a COVID perspective was actually landing in the UK 6 months later. So we were able to predict and start to see some of that learning and try to think some of how that benchmarking and learning space really helped us to think about networks for our policy workers and our professional bodies. It also demonstrated that actually COVID gave us different directories and how the pandemic changed services that we delivered because of increased demand. And we saw during the pandemic a number of elements around mental health, around anxiety, depression starting to rise, mostly because of the challenges of the COVID, but also there's a level of complexity and acuity which have been absolutely identified. And what this also did, it helped us through benchmarking, helped to identify that cross-country service pressure. So where were the pressures? And we've already heard this morning, things like workforce, things like data, are the things that really, really matter to us about actually how do we think about where there are some enablers and levers in the system to try and make a change to that unmet need. Next one, please. So we recognised that actually there were limits and within our findings, and actually we included mental health and health spending, inpatient community services for adults, young people and children in our report that was delivered. We realised that actually there was quite a lot of coherence across the countries in the areas of care, and there was quite a lot of similarity in the approaches that took place. But actually, we also recognise there was quite a lot of variation in the way that data was recorded, the way the quality of the data, but also there was a real challenge around differing service models, and the population differences as well was also very, very key to us to understand. Because what we've recognised actually is that because we've seen an innovation work in one country doesn't necessarily mean that it will lift and shift directly into another one. It's all about context specific. But what we did through the benchmarking network was actually realise that actually there's a real international special interest in this area, particularly led by Kirsten Winfer and the team and Daniel behind the scenes, to really help us think about how we focus on those community services, things like restrictive inpatient practice, and actually how we talk about outcome measurement. And interestingly, I've just been away with the Collaborating Centre for WHO in Paris and in Lille for the last couple of days, and actually trying to understand actually where the maturity level of benchmarking is across the world, and particularly across Europe at the moment. And England is in a really good place comparatively to some of our countries that we're operating in across the world. But we still recognise there are data gaps, and we need to make sure that we've got robust comparable data. And how do we do that across the system? Next slide, please. So I wanted to show really a little bit of a map, a couple of slides that really focus on some of the things that we learned during the benchmarking report. We quite often go to length of stay as a really good indicator around what's happening in the system. And this was a difference between 2019 and 2022. And we saw that starting to be a shift in the way that the system operated, and the use of data and the use of beds was really, really thoughtful for us. So we saw the mean average in 2019 was 37 days for average length of stay. Back in 2022, that had dropped down to 36 days. But comparatively, in 2017-18, that was 42 days from a mean operating position. So actually, we can see that actually we're starting to make a difference, particularly here. And then you can highlight some areas of interest, actually. For example, Sweden and Australia have got lower levels of inpatient lengths of stay. But actually what this doesn't necessarily include is some of the comparative data under the system. So it enables you to be a little bit curious and say what's being counted and what isn't. And particularly for England, actually, at this point in time, it included the eating disorders and secure units in the overall data. So we had to be thoughtful about, so actually we've got a high level there, but actually, is it high in reality comparatively? So, and we actually adjusted for that, which meant it was about 105 days rather than 125 overall. Next slide, please. So then we started to think about the number of psychiatry beds. Again, it's really, really important. We hear lots and lots of stories, particularly around Trieste, around the ability to think about how do we reduce the bed base. And actually, this was the psychiatry beds per 100,000 population. And it highlighted to us that the Swiss population was really notably higher than everywhere else within the group that we were operating in. It had, I think it was 108 beds per 100,000 population, whereas actually some of our areas down the bottom end were less than 25 beds per 100,000 population, which again was really thoughtful about actually how we do that. And so we just wanted to make sure that started to think about, so what does this actually mean? And actually one of the things that we're really thoughtful about here is actually what is the data here for commission service in the NHS system comparative to that in the private sector. And again, context is really specific here because actually quite a lot of our European colleagues operate within a healthcare insurance process. So what's actually locally owned, what's nationally owned, how does that deliver? Again, it's really helpful. And the full report that's available is actually really interesting reading if you haven't seen it already. Next slide, please.
Sean, we have got a hand up, so I don't know if you want to take questions as you go through, or would you prefer to wait till the end?
I'll happily take a hand up. Sorry, I didn't see that. Forgive
No,
me.
it's okay, absolutely fine. Can someone just support with enabling? There we go. Hopefully you can take yourself off mute
Hi,
and
Kate.
ask the question. Oh, maybe not. Do you want to come in? I think you should be able to take yourself off mute, Kate, if you wanted to come in. Maybe not. Maybe a rogue
Okay.
hand. No
No
problem.
worries at
If
all.
people do want to, well, I'll keep an eye out.
Brilliant. Thank you for that. Forgive me. I'm operating two screens, so I struggle to see the hands in between.
No
So,
worries.
so thank you. So we talked about length of stay for bed occupancy. I think the next slide, then, sorry, that slide talks to me about actually we've got a real again difference in length of stay. Now here we had length of stay for adult psychiatry beds. Was the average was about 27 days in Ireland, which is the south of Ireland, was about 53 days, and then right the way down to Sweden, down for 9 days. So it's really, really interesting. But we were trying to think about then actually, was some of that to do with legislation? Was some of that were those people who were voluntary held compared to people who are involuntary held? Some areas operate where you can only be held in hospital if you've actually been detained under the Act, whereas others enable you to be voluntary held too. So again, it's just making sure that when we get the data that we really understand what is really, really happening in the system. And we also understand that the Czech Republic had a lower occupancy level at 56%, which I thought was really, really fascinating. So we heard all earlier today about occupancy rates of averaging about 95%. But actually what's happening in Czechoslovakia then, sorry, in the Czech Republic, really to really think about then what was going on in that system then to be an operating level of about 56%. What we also suggested actually therefore that the bed availability was probably the driver of occupancy rather than necessarily the having patients. And what we also recognise that actually there's a number of areas that actually included in the data when a patient was on leave in their bed occupancy space. So actually we're not comparing apples with apples again, as we were describing earlier. So it's really thoughtful about how you really get into this when you start to unpick it. Next slide, please. The bits for me, again, that really interesting for me is around detention rates and emergency readmission. So detention rates are very, very low, again, in some areas. So 67% for New Zealand, down to 15% in Canada. Now, this is actually detention rates generally under the Act, under the mental health legislation. So some, as I say, some people operate a system where you can only be detained in the hospital if you are there under the law, but whereas others you can attend voluntarily. So this is really, really interesting. And the readmission rates actually for me is actually it's typically within that 28 to 30 days. So, trying to navigate that system internationally to say, actually, who is doing this well and what are the reasons for example, New Zealand or Australia having higher emergency admission rates? Could it be that actually people have been released too early, or is it actually they're doing a really stepped approach to delivery and therefore people are coming back in? So it's just useful, again, from our perspective around being curious about what the data is telling us. Next slide, please. So forensic beds again is a really interesting one again to say that actually high levels of forensic beds per 100,000 populations. The Netherlands actually had a very, very high level actually comparatively to Ireland. Now, some of that is because smaller populations versus high level populations. But actually, you would suggest that actually it should still be about relevant. But the Netherlands was about 17 per 100,000, whereas in Ireland it was 7. So sorry, 3 in Ireland. So very, very limited, but really, really interesting for us to think about. But this also, the UK data only includes bed by the NHS providers, so it didn't include the charity sector or the sort of the private sector that operate in our worlds. So we're just really thoughtful about, when you're looking again at the slides, is it really the true reflection, or actually what do we need to think about when we start to ask the questions? Next slide, please. So children and young persons psychiatry beds, very, very similar to what we saw before. And again, it's just really thoughtful about how that operates. And again, you know, Canada has the lowest there comparatively, still with the Netherlands with the highest level. Just again, that's really important for us just to recognise that actually the notable proportion of mental health beds for children and young people are provided by the independent sector in the UK, and therefore the position shows these countries in underrepresentation from the total number of beds available. So again, it's just making sure that we do understand the data going behind it. Next slide, please. We talk about length of stay and bed occupancy for children. Again, this is really, really interesting for me, just about actually that on the left-hand side, we have the length of stay versus bed occupancy. And we were showed in the adult beds earlier, sort of a 95% sort of mean rate, whereas for the children and young people bed occupancy, it's between 80 and 51, I think, percent. So it's really, really thoughtful. And actually looking at the average length of stay in Australia, it's 9 days, to Sweden, and 125 days for England. So it's useful to understand actually, so what are we doing? And we've seen some really good examples in Sweden actually, and the Netherlands, of work that's been done to really think about how they reduce the length of stay, much more community engagement. And I know we've got some CAMS conversations later on today to work through some of the amazing work that's going on in the UK and England particularly. So hopefully you'll be able to pick up a little bit on that this afternoon. Next slide, please. So restraint is, again, just a useful one to think about. Actually, what I was really fascinated when I saw this is actually the use of restraint in children and young people psychiatry compared to the adult population. It's really significantly higher used. When you look at the notification for Sweden, the Swedish data only includes physical restraint. In Sweden, you're not allowed to prone restrain. And pharmacological restraint is not included in the data provided. So actually, again, we're not comparing apples with apples in this sense, but it gives you a sense of where the data is across the board. Next slide, please. So working with the benchmarking network, we've got a number of reports that we've operated with them over the last few years. They're all available on the benchmarking network, so we can put the links in the chats or via the slides to you. The report I've just gone through briefly, the International Benchmarking Report, is on the NHS Benchmarking site under 2022. And that's a really, really good report, actually commissioned and delivered by the Benchmarking Network. So a really big thank you for all the work that was delivered in that space to help us think about those international collaborations. Next one, please. So we talked at the very beginning about our leadership exchange. We bring together about 600 members from all over the world to talk about a number of topic areas. We had our last event last year in the Netherlands where we ran in-person matches. So we run effectively a 2-day in-person immersive knowledge exchange on a particular topic area. In the Netherlands, we had 34 last year across mental health, addiction, substance use and disability. Anything from the topics I described earlier around rural behavioural health, cities and regions, benchmarking. And that was really, really fascinating. Then on the Thursday, Friday, at the end of the week, we bring everyone back together for a conference where we highlight and showcase some of the learning that's taken place in that beginning of the week. Our link is there on the website for you to have a look at the previous ones. Next slide, please. So just a couple of photos. You know, we have a real mix of people coming to our events. We were very lucky to be visited by the Queen of the Netherlands at our last event. But our panels are really, really interesting, and we have a real mix of Indigenous leaders as well from all over the world, right the way through to children, young people and family networks, right the way through to people with lived and living experience and peer leaders. So it's a real opportunity for leaders to get together and share knowledge and experience. Next one, please. So our next event is taking place in Canada in June next year. We will be running an international benchmarking collaborative for 2 days in Canada, where we'll be focusing on learning, hopefully building on a data capture piece of work that we're doing at the moment with our international network, and hopefully then showcasing some of the learning from that, and then taking that into our leadership event then at the end of the week on the 1st to the 5th of June next year. If you want to scan the QR code to become a member of GLE, as I said, if you're in the UK, it's free to join as a member. Some of the countries from abroad, it's also free to join, and we're really happy to have more people join our network and be involved in the conversations that we're having and brokering that networking opportunity. Next slide, please. So what we wanted to demonstrate really is that members come from all over the world that show immense goodwill to leading change and learning about new or different ways of work. What I've showed to do today is an element around our benchmarking network, is around really showcasing some of that international learning where we get the data, we can be a little bit curious around what we're seeing, and then actually take a deep dive underneath it to get some really valuable learning from, and then go into the countries to get a sense of what are you doing and how are they doing that. And certainly when we do our leadership exchanges, the visits that we do during those first 2 days of the immersive knowledge exchanges give you an opportunity to really get on the ground and see what's really going on in the world in that space. And that's been really, really valuable. And just as an example, I've just been out in Lille in France for a couple of days, and actually went to see a clubhouse to think about actually how they're integrating lived and living experience and work, getting people back into work. Actually, it was a really fascinating project. But really, the interesting bit that was for me was actually how they measure impact and data, and how that's an emerging journey for them actually. So really happy to take any questions. Thank you all for listening, and hopefully some of you will join GLE as members if you're not already. And just a big thank you to our NHS benchmarking partners who've done an amazing job with us over the last few years. So thank you so much.
That's great. Thank you so much, Sean. And it's great to be a part of this as well. And just to say that we have started the data collection with our international colleagues, and the data that we've been showcasing throughout the day today from our UK kind of members and users will feed into that international benchmarking work that will culminate in Canada next year. So really great to be a part of. I haven't seen any questions come into the chat. We are just about on time, but if anybody does have any questions, please raise your hand. Otherwise, we will share the slides afterwards and your contact details, if that's okay, Sean. Fantastic.
Thank you so much.
Brilliant, thank you. I can't see any questions, so I will move us on to our next section, which is the findings from the Children and Young People's Mental Health Benchmarking Collection. Thanks, Alison.
Thank you, Emma, and thanks everybody. I realise some of you may have been on for several hours at this point, so many thanks for sticking around this afternoon to hear the latest findings from this year's Children and Young People's Mental Health Benchmarking Project. So I'd just like to begin with some acknowledgements. So a massive thank you to all of you who contributed to the 2025 Children and Young People's Mental Health Collection. A huge amount of work goes into each of our projects. So many thanks to all the provider organisations on the call who contributed. Throughout the data collection and validation process, we realise it is a very intense process. And the validation is rigorous, but it is so important so that we're confident that the data we're reporting back to you on days like today is accurate. So yeah, many thanks to all of you across exec teams, BI teams, across our provider organisations. Thanks also to our mental health reference group, who are an invaluable steer to us, and our steering group of the network as well. Attendees to all our events, including this one, so many thanks all for being here, and everyone behind the scenes at NHSBN as well. There are many people who contribute in some way or another to all of our projects, so massive thanks to everyone who's made this possible. I'm just going to kick off then with some context for the project. So for those of you who aren't aware, this is the 14th year that the Benchmarking Network have delivered a benchmarking project around children and young people's mental health services. So we have a very long history now of running this project. The data presented today relates to the 2024-25 financial year. So for the kind of year long metrics, that is from the 1st of April 2024 to the 31st of March 2025. And then for the other metrics that are kind of at a point in time, that point in time is the 31st of March 2025. This year we received 98 submissions across 64 organisations, so that constituted 81 mental health providers in England, 4 health boards in Wales, and 12 Scottish health boards and the states of Jersey. So massive thanks to all of you. It is really, really positive that we have such a broad sample across the nations of the UK. I'm just going to share now very high level statistics in terms of just the volume of data that this represents. So collectively, we received data reporting 659,000 referrals received, 580,000 referrals accepted, 227,000 patients on caseload, 3.7 million contacts delivered, and 17,000 total whole-time equivalent staff in post in community services. So that is a huge, vast data set that we're looking at. And then in terms of inpatients, similarly, 1.5 thousand admissions, 913 mental health act detentions, 514 beds, 123,000 occupied bed days, and 2,500 total whole-time equivalent staff. So yeah, just to give you a sense of the volume and the scale of the data that we're looking at here. Hopefully that's given a bit of a taster. So in terms of the outputs from the project, of course, there are the findings which I'll be presenting today, which is quite high level. There are also our bespoke reports, which each provider organisation will now have received at the end of October, as shown on the slide. Within the reports, there are several dashboards which kind of give you these scale charts with where the red diamond is representing the submission position in the range of the whole sample. So these are a really good way to have a high level overview of the findings for your organisation. The arrows on the slide just demonstrate that there are links throughout the report that take you to the online toolkit where you can explore these metrics in more detail. Both the report and my presentation today are going to be primarily focused on general community children and young people services and general admission adolescent inpatient services, with some exceptions to that. But if you are interested in looking at any of the metrics for other team types, eating disorders, crisis, forensic, etc., you can just go to the toolkit and change the team type and look at that. So we really encourage you to and thanks, Shania. Yes, please look at the toolkit if you want to see more detail and more granularity behind some of these metrics. Okay, so I'm going to kick off with some key metrics from community services. So looking at service model, first of all, the vast majority of respondents to this question indicated that they did have general community CYPMH services, MHSTs, eating disorder services, and crisis services, with around half of respondents indicating that they had a neurodiversity team, whether that be ASD, ADHD, or an other neurodiversity team. There were also quite a high proportion, about 80%, indicating that they had an other kind of specialist team. That is a sort of catch-all for any other specialist services which aren't included elsewhere in that list. So that can be made up of lots of different things, but that just means that everything is then included in the totality. Looking at single points of access, Again, the majority reported having a single point of access to general services, with a high proportion also reporting single points of access in eating disorders and crisis services, and in other neurodiversity teams and other specialist teams. Looking at patient outcomes, really positively, 99% of respondents indicated that they did use outcome measures for children and young people, and that they were using those collected outcome measures to inform care, which is really positive. We also asked about which outcome measures we used, and we have collected that data. I've just put the link on the slide. If you want to go look at that in a bit more detail, there are many outcome measures that were reported. We're really interested in outcome measures. Obviously, this is an area of focus at the minute, and if you have any thoughts on how we might be able to actually benchmark outcomes actually relating to patient outcomes rather than just kind of are they being used and which ones are being used, then please do let us know. We're really interested to kind of do more work in this area in future, so please do put in the chat, or feel free to kind of get in touch via email if you have any thoughts that you'd like to share around how we could do more with outcomes. Looking at referrals next then, so we looked at the volume of referrals going into different team types just to give an indication of the scale. So around 54%, so just over half of all referrals were going into general community CYPMH teams, which is why that is the focus primarily of these findings presented today. However, the other half, or around half, were made up of several different team types. So around 11% going to mental health support teams, around 9% into crisis teams, and then a range of other teams. So within the kind of neurodiversity space, 3.8% were to ADHD teams, 6.5% were to autism spectrum disorder teams, and 8.5% to other neurodiversity teams. I've just seen the question about what other teams are. Yes, we do ask a narrative question around that. So if providers are submitting data under other, we do ask them to explain what that is in a narrative box, which we can share. It is obviously hard to quantify because there is lots of different nuances to that, but we do have some information on what they're made up of. Okay, so just moving on then. Oh, I seem to have lost a chart. The referral to treatment time pathway is actually very similar across the last 2 years. So there hasn't been all that much change. For 30% this year of patients were seen under 4 weeks, and 27% were over 18 weeks. So very similar, but a slight positive change. In terms of waiting lists and pathways, so this slide just explains a little bit more about the volumes at each stage of the process. So as of the 31st of March 2025, there were 175,000 children and young people waiting for a first appointment. This was 10,000 more than what was reported in 2024, so that does show a notable increase. However, I just want to caveat that the participation in this project does change year on year, with some trusts, for whatever reason, maybe not able to submit this year who submitted last year, and vice versa. So this is just an indicator. It is not a perfect year-on-year comparison, and actually that caveat is across all of our time series data that I will present throughout this presentation. So the time series should be taken as an indicator, but it is not always a perfect comparison. In terms of waiting for second appointment, this year there were 80,000 children and young people at this stage, which is actually a reduction from last year where there was 86,000. So we've kind of seen that flipped. So more waiting for a first appointment, but less waiting for a second appointment, which is interesting. Overall, the total children and young people on waiting lists this year was 255,000, which is an increase of 4,000 on last year. So fairly similar overall. Again, just a opportunity. If you have any insights that you want to share in the chat around how you quantify your waiting lists and waiting times, we realise that the methodology of first and second appointment is not necessarily being used across all services anymore, and that there are different ways of capturing who is on a waiting list and what they're waiting for. So if you have, I think, you know, we did ask this in the spec as part of the collection this year as well, for people to kind of share their thoughts. But if you do want to share how you're collecting waiting times or waiting lists within your service, if it's different from this, then we'd be really interested to hear that. Okay, I'm going to move on. So looking at some key metrics, caseload per 100,000 population in general CYPMH services has reduced slightly this year compared to the previous year, whereas the contacts have increased slightly based on the last kind of 3 years. That may indicate a greater intensity of contacts being delivered. So for contacts delivered per patient on caseload may be increasing. I just also want to reference that in 2023, we added additional team types to the collection. And previous to that, activity may have been recorded under general services that is now recorded in those other team types. So that may explain part of why both of these metrics seem to drop a little bit in 2023. However, it may also have been to do with kind of post-pandemic recovery. So just wanted to make that sort of disclaimer, really. Looking at contact mediums, I won't dwell too long on this because actually it shows that there is very little change in the last year. We did see this change very significantly during the pandemic, obviously with a big reduction in face-to-face activity, and then there was several years kind of recovery post that. But this shows that the contact delivery medium is very stable based on the change from 24 to 25, which perhaps indicates that this is the new normal, and this has settled down following the pandemic. I'm now going to look at some key metrics across team types. So just as a bit of a summary. So first of all, looking at referrals received per 100,000 population. As I showed earlier, general CYPMH teams receive by far the vast majority of referral requests. MHSTs receiving about 814 referrals per 100,000 population. Fairly similar in crisis at 677. And then eating disorder, around 150, quite a significantly less, and then forensic by far the smallest team type. I'm going to focus on waiting times because I think this is a really important metric. The average wait to first appointment this year for a general CYP team was 4 weeks. This is a reduction from 5.5 in 2024, which is really positive to see. And in terms of the waiting time to second appointment has also reduced from 12 weeks to 10. So that's really good to see. In mental health support teams, again, the waiting times have reduced to first appointment from 2.4 to 2 weeks, but have increased slightly to second appointment from 4.5. Sorry, have also reduced from 4.5 to 4.2 weeks to second appointment. Eating disorders, waiting time to first appointment is the same as last year at 2 weeks, and crisis is very similar at 0.9. It was 0.8 last year. In terms of forensic services, these are very few providers have forensics services, and therefore this team type statistics are a little bit more volatile in terms of their change year on year, but that has increased to 5.7 weeks from 4.1 previously. I've just highlighted on the slide there the referral to treatment time for eating disorders and crisis, fairly understandably, the percentage of patients whose referral to treatment time is less than 4 weeks is significantly higher in eating disorders and crisis teams than it is in any of the other team types, which makes sense given the acuity of those services, but it is interesting to highlight how different that is to some of the other team types. And then caseloads, the pattern very similar to referrals in terms of the relative volume per 100,000 population served. Next, I'm going to look at treatment intensity. So the way we work this out is it is a crude measure, but it is an interesting indicator. So we're looking at the average number of weeks patients spent on caseload, the average number of contacts they received before discharge, and using this to calculate the approximate number of contacts they received per week. So for general services, patients received an average of 10 contacts before discharge over 35 weeks, which gave an average of 0.3 contacts per week. For MHSTs, patients received an average of 9 contacts over 16 weeks, which gave an approximate 0.6 contacts per week. In eating disorders, patients received an average of 22 contacts over 36 weeks, which gave the same average contacts per week, which was 0.6. And then finally, for crisis services, patients received an average of 5 contacts over a much shorter time on caseload, as you would expect, of 3 weeks, which gave higher treatment intensity of 1.7 contacts per week. I'm now going to look at workforce in community services. So the workforce has remained fairly stable over the past few years. We're now at around 79 whole-time equivalent per 100,000 population. So that is a reduction of about 4 whole-time equivalent from last year, but broadly consistent. In terms of the vacancy rate, the median this year was 14% in general CYPMH services. Obviously, as you can see on that chart, there is a wide range. Each of these bars represent a separate submission. I will just say that that bar at the top has been validated, and that is just a very small service where obviously a very small number of vacancies make a huge impact on the rate, but that is correct. Moving on to look at discipline mix. This is a really interesting one in community services, and I think the difference between community and inpatient discipline mix is obviously very stark, and I would suggest you keep this in mind when we get to the inpatient sector, because you'll see it is a very different picture. But in terms of in community, 27% of staff were nursing and clinical support, and I will just say that of that, 22% were qualified nurses and 5% were other support staff. Allied health professionals made up 3% of all staff and posts in general community teams. 7% were medical staff, 32% were staff working within psychological professions, 7% were social care and community roles, 21% were administrative and management staff, which is interesting, an interesting difference between adults and older people services, where those administrative and management staff aren't as don't make up such a high proportion in adult services, and then 3% were in other. Looking at finance, bank and agency spend as a percentage of pay costs, has remained very similar to last year. So looking at about 5.7% of pay costs. That's really positive that has come down in the last couple of years compared to the years before. Obviously, maintaining a consistent workforce is really positive in terms of patient care and patient experience. Looking at the total cost of service per 100,000 population, that has reduced this year compared to last year, but is more consistent with the previous years prior to 2024. So 2024 was a bit of a peak, but that appears to have stabilised more in line with the years before that. I'm now going to look at productivity specifically. As Danny mentioned earlier, for those of you who were online for the adults findings, productivity is a huge area of focus for us this year, as I know it is for many of you too across the NHS. And so we have not only on our toolkits, but also in our reports and events focused on this area and in terms of what insight we can gather on this topic from our metrics that we collect. So the first and I guess clearest measure of productivity that we have in children and young people's mental health services is contacts delivered per clinical whole-time equivalent per day. And I just want to take a minute to just explain how we calculate this and some caveats around it. So this is calculated as the total number of contacts delivered divided by the number of clinical whole-time equivalent staff. Now, that is not just medical staff, that is all staff excluding admin and management. So just want to be really clear what that includes. And then that is divided by 220, which is the average number of working days in the year in the NHS. So it is a crude measure. I want to make that clear from the beginning. It should not be looked at without context. I think every single benchmarking metric, we would always say, it should not be looked at in isolation. It is an indicator and should be looked at in the context of other indicators at a service level. We're also aware that, not every member of staff is entirely patient-facing. They may have other responsibilities that are part of their job where they're not delivering contacts. However, to kind of factor that in at an individual staff member level is incredibly complex. So what I would say is that should average out over a whole service, over a whole nation. And so just take this as an indicator within that context. So getting into it then, the contacts per clinical whole-time equivalent per day had been reducing for the last 4 years, down to 1.28 last year. However, it's really positive to see that has bounced back a little bit to 1.4 this year. However, it's still not that high overall. So I think important one to keep an eye on. And I think it's definitely an interesting one if you are joining us as a provider who has submitted to this project, something to go look at in your own bespoke report or on the toolkit to see where you compare on this. Looking at this across team types, there is variation across the different team types in terms of their rate of contacts delivered per whole-time equivalent. As I say, in general services, this is 1.4 in 2025. In MHSTs, this is 1. Eating disorders 1.1, crisis 0.9 and forensic 0.6. So no service reporting over 1.5 contacts delivered per whole-time equivalent per day. And in fact, most of the services reporting around 1. The next thing we're going to look at is did not attend rates or was not brought rates in CYP. Really positive to see that the median DNA rate is the lowest we've ever seen in general CYPMH this year. So just marginally below what was reported in 2021. And while that is absolutely positive, it is still a high rate of appointments where the patient is not attending. So almost 1 in 10. Interesting to see as well that this varies a lot by team type. So it's the highest in general CYPMH services, but reduces to 6.27 for mental health support teams, just over 5.5 for eating disorders, just under 3 for crisis, and around 2% for forensic services. So looking at costs then, again, this is a crude metric, and I'll just explain how it's calculated. So the way we The way we calculate cost per DNA is looking at the total cost of service divided by the sum of the contacts delivered and the contacts that weren't attended. So it is effectively cost per appointment, which is also the cost of each DNA. And that just highlights really, I guess, how much is potentially lost in terms of unattended appointments. And then the next chart is the overall cost of DNAs, and that's the cost per DNA, which is the first chart, multiplied by the number of DNAs within the service. And as you can see, that has a huge range across the different services. It has a median of £500,000 per year lost to DNAs potentially. So again, this is just an indicator and it is crudely calculated, but it is a really interesting chart that just highlights potentially the impact of unattended appointments and maybe demonstrates the potential benefit of investing in measures to reduce unattended appointments and the potential saving and increase in efficiency that could be made from that. And then the final metric for community services is looking at the average time on caseload. So I'm not going to dwell on this too long because as you can see, it's remained fairly constant across general CYPMH teams across the last few years. However, it is something that I think if as a trust, as an organisation, you're looking at this and you're benchmarking particularly high, there may well be context for that that is local to you that you know. But if you are benchmarking high, it's something, I think this is a really important metric to look at in terms of, are there measures that could be taken to improve patient flow through that pathway that could then help reducing waiting lists and things like that. And unsurprisingly, it varies quite a lot across the different team types. So 3 weeks median on a crisis caseload, for example, varies right up to 37 weeks for forensic services. I'm conscious of time, so I'm going to move on to inpatient services. So just to give you some key metrics in this area, again, looking at the bed types as an overall volume, the vast majority of beds that were reported as part of the collection were general admission adolescent beds, making up 70% of all beds that providers reported to have. The next highest was psychological intensive care, PICU beds, 9% around, 5.6% general admission children's beds, 7% were medium secure beds, 5.6% were eating disorders, and 2.1% were low secure. So that just gives you the bit of context around the different bed types and how what volume they represent. Okay, looking at general admissions per 10 beds, that is consistent with last year. That's remained at 30 as a median. However, the percentage of inpatient episodes where the patient was detained under the Mental Health Act at the point of admission, that is a very long title, has steadily increased over the last 3 years. So it was 49% in 2023, 60% in 2024, and now 65% in 2025. So that really indicates a growing acuity of patients coming into the service. I've pulled out here the average length of stay excluding leave and the bed occupancy rate excluding leave for all the different bed types that we collected, because I think it just gives a really interesting view of the different services. And what you can see is that the average length of stay for children is around 5 months, 148 days. The general admission adolescents actually have the lowest length of stay reported this year, around 2.5 months or 78 days. And then right at the bottom, you can see quite starkly, low secure and medium secure beds have much higher length of stay, as you might expect. But that does suggest that for low secure beds, the average length of stay at point of discharge is around 2 years, and for medium secure, that is around 1.5 years at the point of discharge. So very stark differences then in the different lengths of stay. In terms of bed occupancy rate, so this is again is excluding leave, and this is calculated as occupied bed days excluding leave divided by the total number of available bed days within the service in year. I won't go through these one by one in the interest of time, but there is, as you can see, quite a bit of variation between the different bed types there. Okay, looking at average length of stay. So as I just said, for general admission adolescent beds, this is around 78 days this year. So this has increased, as has the bed occupancy rate up to 63%. So they probably go, well, they go hand in hand in terms of the average length of stay has gone up, and therefore the occupancy has increased as well. Still, in terms of average length of stay, still not as high as what was reported in 2023, though. So we've seen a bit of a dip last year and increase this year. Now, this is a really interesting chart in terms of looking at the profile of the patient's length of stay at the point of discharge versus the occupied bed days that were occupied by patients whose length of stay at the point of discharge were within those bands. So what this shows is that 77% of patients were discharged within 90 days. However, they accounted for just 41% of occupied bed days, around 2 in 5 occupied bed days. So the flip side of that is that around 3 in 5 occupied bed days were occupied by the top 23% of long stay patients. And this shows that difference really nicely, I think. Again, it indicates that improving that patient flow, where possible, and getting the long stay patients discharged where appropriate really helps in terms of reducing those occupied bed days and improving the availability of those beds. Going to quickly look at restraint. I have also referenced general admission children's services on these slides, but I do just want to caveat that there are very few general admission services compared to general admission adolescent services. So these medians are based on a fairly small sample of providers, and that also has changed somewhat over the last 3 years. So the sample size for the children's services is smaller than the adolescent. But positively for both children and adolescents, the incidences of restraint per 10,000 occupied bed days has reduced across the board, which is really positive to see. In terms of prone restraint, this has reduced again across the board, which is really positive. It was higher in children's services last year than in adolescents. Again, with a small sample size, though, that is quite open to being volatile in terms of that year-on-year change, whereas it appears much more stable across the adolescent services. Quickly looking at workforce for inpatients, this has reduced per 10 beds over the last 3 years, so going from 38.2 to 38 to 35.3 whole-time equivalent per 10 beds. But, you know, no drastic change there. Overall, fairly stable. Vacancy rate in inpatient services was 21%, so higher than the 14% reported in community services, and that has been consistent with previous years in terms of inpatient services reporting a much higher vacancy rate than in the community setting. Looking at the discipline mix of inpatient general admission adolescent services, so as I mentioned earlier with the community one, where there was much more diversity of staff types, there was a much higher proportion of psychological profession staff and a much higher proportion of admin and management staff, just to reference a couple. The discipline mix in inpatient setting is much less diverse, with 73% of staff being nursing and clinical support, and of that 34% were qualified nurses and 39% were other clinical support staff. But we see 4% of allied health 4% of staff were allied health professionals, 5% were medical, 5% were psychological professions, just 1% working in social care and other community roles, 9% administrative and management staff, and then just 2% in other roles. Finally, for inpatient services, just having a look at finance. So bank and agency spend reduced to a median of 23% this year, which again, similar to community, has gone down, which is positive in terms of that consistent and stable workforce. And then in terms of total cost of service per 10 beds, this has reduced slightly on last year, but is still higher than what was reported in 2023. So a little bit of change there too. Okay, that's the end of the inpatient section. I'm now just going to go through some data on health inequalities. This, along with productivity, is a really key area of focus for us. And I'm just going to take the last sort of 8 minutes of my time to kind of talk through some of the data we have around health inequalities. So these double donut charts show the population ethnicity. So that's the 0 to 17 population of the UK, of the whole UK, in the outer ring. And then in the inner ring, that shows the totality of children and young people that were reported on community caseloads, and similarly in the inpatient setting that were reported to have been admitted to an inpatient setting in the last year. The first thing I want to draw your attention to is the very pale pink section within the two inner rings, which is those whose ethnicity was not known or not stated. This is a really high proportion, and we'll see when we get into the ethnicity by teen types of patients whose ethnicity was not recorded. And I think that just highlights how important it is that patient ethnicity is recorded, because that makes it really hard to look at under and overrepresentation of different groups within these settings, while such a significant proportion is unknown, and could be potentially disguising or making more unclear issues with access to services or issues with representation. So yeah, key message from this is how important accurate demographic recording is. Okay, so we're going to look at first at ethnicity of patients on caseload by community team types. Again, the pale pink section at the end is where their ethnicity has not been recorded or is unknown. Across the different team types, we can see that in comparative to most of the teen types, Asian British children and young people are underrepresented, except in ASD services. And similarly for Black and Black British young people are underrepresented in most services except ASD and forensic services. So that it suggests that there is, inequity of access to services, and we'll look when compared to inpatient services, where we can see that especially Black and Black British young people are overrepresented in PICU and medium secure services, that there is underrepresentation in the least acute settings, so in community settings, but overrepresentation in the most acute settings in the inpatient, that there is that children and young people are not able to access services when their need first emerges, and are instead only being picked up by services at a point where they're very acutely unwell, which does tell a story around that inequity of access to mental health support for children and young people from ethnic minority backgrounds. I'm conscious of time. Looking at gender very quickly, in community settings, we see a fairly even gender split with a slight overrepresentation of male children and young people. However, in inpatient setting, this really this tells a very different story, with almost 2/3 of admissions being from female children and young people. Again, there is quite a bit of variation across different team types. So in general services, that is a fairly even split. But looking at MHSTs, eating disorders, crisis services, primarily female children and young people accessing those services, whereas forensic and neurodiversity teams, so ASD, ADHD, and other neurodiversity teams being predominantly male, which perhaps suggests an access gap in terms of female children, young people being able to access neurodiversity support or diagnosis. And then in terms of admissions to inpatient settings, again, this is very variable. So females make up the majority, but around a third of admissions to general admission, both children and adolescent services. But 98% of eating disorder admissions were female, with just 2% male children and young people. PICU was fairly even, but low secure and medium secure telling a very different story, although the number of admissions to low secure and medium secure services are so few that can be fairly volatile and influenced by it's a very small sample making up that low secure and medium secure admissions. Finally, in terms of learning disability and neurodevelopmental profile, we asked this year for the first time if provider systems could use flags for patients with a neurodevelopmental profile or a diagnosed learning disability. Across all services, there was a bit of variation. However, across the board, it was less than half said that they could, which again indicates that the reasonable adjustments that these patients may need may struggle to be implemented if their diagnosis or neurodevelopmental profile is not flagged on their patient record. And then finally, just looking at training. So in terms of for patients with learning disability, the percentage of staff with up-to-date Oliver McGowan training varied very significantly across the different team types. So from 100% of MHST staff, nearly 98% of eating disorder staff, right down to just 61% of staff in ADHD teams reporting that they had completed Oliver McGowan training. So that is a key focus in terms of making sure staff are best equipped to look after patients with potentially additional needs in that area. And I think I'm just about on time, so I will pass back to Emma. But thank you all for listening. Any questions, feel free to pop in the chat and I will get back to you while the next presentation is going on.
That's great. Thanks, Alison. So much information there, isn't there, in terms of kind of what's happening across children and young people's mental health services. A couple of comments and things in the chat around some of the productivity metrics around number of clinical contacts per day, but lots of chat between participants, which is great to see. So use each other on the call in terms of sense checking what's happening within your organisations and reaching out to people. But yeah, Alison, if you can have a look through the comments.
Absolutely, will do.
That would be great. In terms of the slides and the recording, absolutely, these will be available after, and your individual participant reports are also available on the members area to dig into your own organisation and service level data as well. So thanks, Alison.